Hi everyone, welcome to researchmd.com. We just got a great topic today. We're going to teach you all about colonoscopy versus home screening for colorectal cancer. That's our topic. Again, my name is Pramil Cheriyath. I'm a program director, internal medicine residency, transitional residency. I teach medical students and residents on a regular basis. I'm also a director of research. So let's get into our topic. So when you talk about colorectal cancer, fourth most commonly diagnosed cancer in the United States, okay? Incidence and account like 8% of all new cancer diagnosed in the US. Peak incidence is between 65 and 74 years of age, and prevalence is around 0.4%. Mortality, third leading cause of cancer-related death in the US overall. Risk factors, positive family history, hereditary syndrome, diet, numerous conditions like inflammatory bowel disease. And when you look at the most common colorectal cancers are like adenocarcinoma, 95%, and then you have squamous cell carcinoma, okay? So clinical signs, most of this like remains asymptomatic, non-specific signs, remember, change in bowel habits we have to worry, anemia is the other common, lower GI bleed, weight loss, so those are the symptoms, tiredness, fatigue also. Some red flags, men older than 50 years of age and postmenopausal women are red flags for colorectal cancer. And so the main goal is to diagnose the cancer early so we can prevent the complications. So, I mean, when to screen for colon cancer, that's next slide. And then patients, like if they're like an average risk, let's say general population, single first degree relative age greater than 60 with the colon cancer or adenomatous polyps. In those group of people, you start screening at age 50. You start with the colonoscopy, okay? And let's say if you cannot do it, then you have to think about other options. You got like a fecal occult blood test or FIT every year you have to do. Then you got the FIT DNA, the new test every 1 to 3 years. You can do CT colonography every 5 years, and you got flexible sigmoidoscopy every 5 years. Now, let's say if you are at high risk, that means like first degree relative age less than 60 with the colon cancer or adenomatous polyps, greater than 2 first degree relatives with the colon cancer or adenomatous polyps at any age, then you have to start screening at early age. That means colonoscopy start at age 40. Or 10 years before the age of cancer diagnosis in the relatives, whichever comes first. Remember that, colonoscopy at age 40 or 10 years before the age of cancer diagnosis in a relative, whichever comes first. And repeat every 3 to 5 years. So patient increased risk, you have to repeat the colonoscopy every 3 to 5 years, okay? Now, how often high-risk patients need screening? Let's say if you have like family history of adenomatous polyps or colorectal cancer, first degree relative age less than 60, colonoscopy at age 40, we talked about, and then 10 years before, repeat every 3 to 5 years. And then let's say like patient have like remember we already said people at inflammatory bowel disease at high risk, right? So that means they have ulcerative colitis or Crohn's disease. You begin 8 years post-diagnosis, 12 to 15 years if disease only in left colon, and the colonoscopy with the biopsies like you have to do every 1 to 2 years, okay? And then you have familial adenomatous polyposis, begin at age 10 to 12, colonoscopy every year, and hereditary polyposis, colorectal cancer or Lynch syndrome begin at age 20-25, and colonoscopy should be done every 1 to 2 years. Okay, so one of the screening modalities we have, always remember the gold standard, nothing better than that, colonoscopy. Okay, and then the other alternatives you have like you can do FIT, or you can do flexible sigmoidoscopy, you got CT colonography. Let's say if you're doing CT colonography or capsule endoscopy, you have to do every 5 years, and the flexible sigmoidoscopy every 5 to 10 years. And stool-based, let's look at the stool-based test, which is becoming more common now. Annual fecal immunochemical testing, which is called FIT. They use antibodies to detect occult GI bleeding at a higher sensitivity for colorectal cancer than the fecal occult blood test. Remember, fecal occult blood test is not a very good test, but look at the other options we have. And let's say annual fecal occult blood test, we can do it, but the sensitivity and specificity is very low. Just be very careful about that. The new test is the multi-target stool DNA test every 3 years, which is called Cologuard. This is a stool-based assay that detects certain mutations typical for early colorectal cancer, such as mutations in the KRAS gene, and is used as a screening tool for colorectal cancer and a positive test. All of this, remember, when you do other tests, the ultimate, if it is positive, you have to do colonoscopy. Remember that. So let's look at some numbers, look at the sensitivity and specificity. Again, we said colonoscopy the gold standard, correct? So look at the sensitivity is around 94.7%, specificity is 99.8%, and then look at the FIT test, that is 93% and 95% respectively, and the Cologuard you have like 92.3% and the 90%, okay? So what are the pros and cons of all the screening modalities we discussed? Colonoscopy, pros, diagnostic, therapeutic, okay? And then it's the gold standard. And then you can detect polyps, diverticulosis, internal hemorrhoids. And the cons is like invasive, and people are like kind of turned off. You have to do this coronary preparation before the procedure, and sometimes, very rarely, can have like perforation and bleeding. And let's look at the FIT test. The process like non-invasive, cost-effective, and then cons is like low sensitivity compared to the colonoscopy. And again, if it is positive, you need to do the colonoscopy anyway, right? And the Cologuard also non-invasive. That's what people like it, cost-effective. But again, you need to be confirmed. I mean, after the positive, you need to undergo colonoscopy. Okay, so we got a nice diagram over here comparing colonoscopy, Cologuard, and the FIT test, and it's clearly written like screen for colon cancer. We already talked about the sensitivity and specificity. At home test, you have the option Cologuard and FIT test. Okay, so if you look at the colonoscopy, I mean, to understand colonoscopy, use the scope to look at the colon, and you can detect the polyps and a lot of good things. I mean, it can detect, all right? And then you got the stool test, you got the fecal immunochemical test. You take the stool sample and get the results, and also fecal occult blood test, you can get it done like right away. The stool DNA test, then you have flexible sigmoidoscopy. The difference is when you do a flexible sigmoidoscopy, the scope does not reach all the parts of the colon, only the upper part, I mean the lower part of the colon, I would say. Then you got, of course, you got CT colonography, but again, you know, you're talking a lot of radiation, so just be careful, and you should know the complication. These are the references. Thank you so much for watching. We'll be back with another presentation soon. Thank you.